Our patient is a 64-year-old man, typical murmur of mitral regurgitation, who's had progressive dyspnea over the past 2 years, has all evidence on echo of severe mitral regurgitation, and in the echo lab has an end diastolic dimension of 6.5 and end systolic dimension of 4.6, an ejection fraction of 55%. And he came to me post-operatively, he had been operated at a different hospital, wondering why he felt so bad. He was still, actually had more dyspnea than he had prior to surgery. His ejection fraction was now 38%. His BNP was 550. And the reason he was doing so poorly is that he and his physician had ignored the current guidelines for the treatment of mitral regurgitation. So that we say that people, first of all, the guidelines make a very strong distinction between primary and secondary mitral regurgitation, two entirely different diseases. But for primary MR, we say that patients should be operated at the onset of symptoms, 60, 50, 40, an ejection fraction going down towards 60%, a pulmonary artery systolic pressure going up towards 50, and an end systolic dimension growing toward 40. And you'll remember that our patient had symptoms for 2 years, an ejection fraction of 55% and an end systolic dimension of 46. He had a shot ventricle that did not respond well to surgery. And so the question is, where did those triggers come from? Well, symptoms are important. Even if your ejection fraction is preserved, if you have severe symptoms prior to surgery, it means that there is something wrong with the cardiovascular system, whether it's diastolic dysfunction of the left ventricle, whether it's right ventricular dysfunction, pulmonary hypertension, coronary blood flow abnormalities. It's not clear why people get symptoms, but if they have symptoms, something bad has happened to the cardiovascular system, irrespective of ejection fraction. So symptoms are very important. Even these data from the Cleveland Clinic suggest that even if the patient has developed class 2 symptoms prior to surgery, it may impact prognosis after surgery. Ejection fraction is important. It's important to get to the OR, whether a valve repair or a valve replacement is performed while the ejection fraction is still above 60%. The normal EF for the patient with mitral regurgitation is about 70%. By the time it gets down to 60, the heart is already in some trouble. It does not matter how much preload you put into the ventricle. It comes down to the same end systolic dimension as long as afterload and contractile function haven't changed, which is why end systolic dimension in the two regurgitant lesions, aortic and mitral insufficiency, is a good marker of left ventricular function. And if your end systolic dimension gets to be more than 40, prognosis is worsened. And our patient had everything wrong with them. Pulmonary artery pressure, the higher the pulmonary pressure, the higher the operative mortality. Here's another patient. He's 64 too, has all the evidence of severe mitral regurgitation with an end systolic dimension of 39, so within the guidelines, and an ejection fraction of 65%. Asymptomatic. So far, left ventricle looks pretty good. Should we wait? Should we just follow this patient along until he develops a trigger? Well, the evidence for that comes from Rosenheck and his colleagues in Vienna, where they looked at what happened if they waited for a trigger and then operated. And the results were pretty good. But the support for early surgery comes from the same study. You don't get to watch and wait very long. Within a few years, something bad happens to these patients. And when Bob Bono took all the data that were available and tried to compound the natural history of mitral regurgitation, most patients get into trouble within about 5 years after you first discover severe MR. So you can watch and wait. You just can't watch and wait for very long, because these folks get into trouble pretty quickly, which may be why in this propensity match study, now this is not a randomized trial, and you can never propensity match for everything. But in this study that Shukri Curry published, early surgery, this looks at survival before any of those triggers occurred. It looked like performing early surgery had a beneficial impact on outcome, and that's why the 14 guidelines say that we would consider it a 2A. Means many people, most people, would consider surgery for an asymptomatic patient who has normal left ventricular function if you were almost certain the valve could be repaired. This doesn't mean that the heart surgeon repairs 95% of his or her cases. It means with that patient, in that echo, with that pathoanatomy, the surgeon is fairly confident that the valve can be repaired. We would say, let's go ahead and repair it now. In fact, if you want the patient's ejection fraction to return to normal, the end systolic dimension should be less than 40 and the ejection fraction more like 64%, which may be one of the reasons in the current guidelines, the 17 focus review, we said that by the time you get to 60 and 40, there's probably already LV dysfunction. There's no need to wait. If you see the patient going in the wrong direction, you might opt for surgical repair of that valve now rather than waiting for a trigger to occur. We move the bar yet further and further towards early surgery. This is the other disease. Primary mitral regurgitation and secondary mitral regurgitation sound a lot alike, but so do tonsillectomy and orchiectomy. Okay? They're two very different operations. And these are two very different diseases that are treated in two very different ways. This patient's had 3 MIs, has severe LV dysfunction, and the consequence of that, the pulling apart of the papillary muscles, the the left ventricular annular dilatation, regional wall motion abnormalities that cause the valve to close poorly, has created secondary MR. There's nothing wrong with the valve. It's the ventricle that has caused the valve to leak. He has far advanced secondary MR. We know that mitral regurgitation is associated with a poor prognosis. So this looks at heart failure with no MR, heart failure with a little MR, and heart failure with severe MR. And you might say, well, even a little mitral regurgitation impacts prognosis. But look again, these hearts are progressively sicker. The ejection fraction in this group was 28, 25, and 24%. The same is true in this study by Rossi and colleagues. Yes, the more MR you have, the worse your prognosis. But look here, look at the ejection fraction, and look at the end systolic dimension. These hearts are progressively sicker. So is the worsening MR the cause of a poor prognosis? Or is it simply telling you how sick the ventricle is? Because if the MR is the cause of the worst prognosis, we should be able to prove it. Fixing it ought to make the patient feel better and live longer. And that's been extremely difficult to prove. Steve Bowling was one of the first people at the University of Michigan to talk about operating on these patients. But there was no difference in outcome between medical and the surgical therapy in those patients. In this study by Castleberry and colleagues, if you look at patients with ischemic mitral regurgitation, severe ischemic mitral regurgitation, where the options are CABG alone, PCI, some coronary revascularization, or medical therapy. The best option actually was PCI or CABG alone. The addition of a mitral valve operation did not improve prognosis, maybe worsened it. In this small randomized trial by Fatucci and colleagues, there's no evidence, not even a signal, that repairing the mitral valve at the time of bypass surgery prolonged life. And in the recent CTSNet trial, which looked specifically at a different issue, it looked at mitral valve replacement versus mitral valve repair and found no difference. But that's not why I'm showing you the slide. At 2 years after surgery, 20% of the patients had died. 10% mortality per year, which is exactly the same mortality from secondary MR as it was when I was a fellow. It's because it's not the valve. We have not developed yet a way of making the ventricle better. We don't, for that, our patient that's had 3 MIs, we don't have any way of replacing the muscle that he lost from his myocardial infarctions. Medicine works pretty well. And this very aggressive use of vasodilators and diuretics 30 years ago by Lynn Warner Stevenson reduced the end systolic volume by 30%, improved forward stroke volume, and made the MR go away. Very aggressive medical therapy can really do a lot to shrink the ventricle and restore mitral valve competence. If the patient has a big fat left bundle branch block, and what you're seeing on this slide are the variety of ways of looking at the effect of cardiac resynchronization on secondary MR, it can be very effective. Surgery will make you feel better. And this looks at that same CTSNet data of replacement versus repair of the effect at baseline and on symptoms, and patients progressively got better. They felt better. They don't live any longer, but they felt better, which is why we say it's a 2B to operate on these patients. We don't have any evidence of a survival benefit, but after you've exhausted medical therapy, including cardiac resynchronization, when it's reasonable, when it's applicable, then you might improve patients' feeling with surgery, which is where the mitral clip comes in. Although in the US it's only approved for primary MR, worldwide it's primarily used for secondary MR. And I suspect that when we get the COAP data, which is the randomized trial of using the mitral clip for secondary MR, we'll see that it has a use there. In terms of the what's new in the current guidelines for secondary MR, the fact that there was no benefit between repair and replacement, we said that it doesn't matter what you do. Either one is applicable. And then we made a mistake. In the 14 guidelines, we looked at data that said if the regurgitant orifice was more than 0.2 square centimeters, that outcome was worse. And we said that that should be one of the markers for severe secondary mitral regurgitation, and we made that a guideline. The error that we made was not looking at left ventricular size. If you have a small ventricle and a regurgitant orifice area of above 0.2, there won't be any blood going forward. You're ejecting 30% of a small ventricle to begin with, and if you have a large regurgitant orifice, your forward stroke volume would be so small that would be compatible with life. So we made a mistake of interpreting that to mean that it was the orifice area that connoted severe MR. It wasn't. It was the size of the ventricle. And so what we said is that we've now restated what severe secondary MR is. It's gone back to the 0.4 square centimeters that we use for primary MR, but also says, look, when you have one of these patients with secondary MR, you need to take into account every clue, including the physical examination, about how much secondary MR there is before you decide that that's what the patient has. And then in the second CTS net trial in moderate secondary MR, whether or not repairing or replacing the mitral valve at the time of bypass surgery had an impact on outcome, we probably guessed that it wouldn't, and it didn't. So in primary MR, we moved the bar even further towards intervention, saying that you don't have to necessarily wait for symptoms 60, 50, 40 if the patient is moving in the wrong direction. And if you are confident that the valve could be repaired, you might opt for early surgery. For secondary MR, we said that the definition of severe secondary MR has to take into account everything you've got, not just the regurgitant orifice area, which was 0.2, and now that's been eliminated from the guidelines. Repair is okay, but it's not preferred. It's always going to be preferred for primary MR, but it's not necessarily preferred for secondary MR. And what to do with moderate ischemic MR at the time of bypass surgery is anybody's guess, but there's nothing to compel you to do that. So hopefully this has been of some benefit in trying to understand the differences between primary and secondary MR and why we said what we said in the guidelines. Thank you very much for your attention.